Good afternoon, everybody, and welcome to this week's Power Hour. This week, we are going to talk about racism in healthcare and equity in health again. And this is going to be our third conversation around this topic, and we will continue to have these conversations on this topic as throughout the fall as well. So do check in and follow us and join every time if you can when we have this conversation. As you may remember, the Power Hour comes to you as an effort to build community, as an effort to build collaboration, and above all, to build conversation about important topics for this community and for healthcare. It is offered to you by Kanof Institute for Physician Leadership, which is housed in the North Carolina Medical Society Foundation. My name is Christina Nattogdag, and with me today I have Aubrey Cuthbertson, who's my partner in crime, as well as our colleague Franklin Walker, who is, as always, the moderator of these sessions. I am going to hand over to Franklin in just a second. I do want to remind everybody about the format. We do invite you to engage with the guests that we have. And as you do, please unmute yourself. So we do ask you to keep on mute if you're not talking. The session is, as always, recorded and is going to be available for you on the Kanof Institute for Physician Leadership landing page sometime around midweek next week. I think I've covered all the logistics. Without any further ado, I'd like to hand it over to my colleague, Franklin Walker. Thank you.
Super. Thanks, Tina, and thanks everybody for joining us today on our third installment of this topic. We have with us today Dr. Karen Smith, Dr. Phil Brown, Artina Dawkins, and we're all with us on our last journey on this one on July 10th, but we're also welcoming Becky Carter and Roxanne Elliott. So again, thanks everybody for joining us today. So, you know, as I said, we talked about this subject on July 10th, and in the ensuing few weeks, a lot has happened. I know that the medical society has really engaged this topic in a lot of ways, and one of the ways we've done that is a new task force on race and reconciliation. And Dr. Karen Smith is the chair of that task force, and I want to ask Dr. Smith if she can give us a little overview about what's going on with the task force, the charge, and maybe some of the recommendations. Dr. Smith?
Yes, thank you so much. This task force is one of the most exciting activities I have done in a long time in healthcare. And it's also one that will make a difference. I'm sure it will. The purpose of this task force is to go back and explore events and the historical past of the North Carolina Medical Society. And the events in particular would be those of African-American physicians were not permitted to have full membership in North Carolina Medical Society prior to the year of 1965. African-American members, or Black physicians, or colored physicians at that time were only granted scientific membership. And as a result, it was quite frankly not right, but it did not allow them to hold privileges at the hospitals in their communities. So a Black physician would care for a Black patient, a white patient, an Indian patient, but when it came time for the patient to be admitted to the hospital, they would have to relinquish the care to the physicians at the hospital, the white privileged doctor, and that clearly was not good for the patient-physician relationship. And it just was not the right thing to do for healthcare or for patient care overall. The other issue was this was a problem that was occurring throughout several states in the United States. And the purpose of the Race Reconciliation Task Force is to go back and explore and talk to these doctors if they are living and talk to their families and to understand what had happened, and then to allow the medical society, the North Carolina Medical Society, to be the first, from what I'm told, to actually recognize that was a problem, and we want to apologize. We want to express with sincerity that whatever was happening during those times, it was not right, And we want to acknowledge it today and use that as a launching pad to move forward as we look to improve health disparities throughout our state as part of a national initiative. But this is what we're going to do in North Carolina.
Wow, that's pretty interesting stuff. Dr. Phil Brown is the incoming president of the Medical Society. I'm wondering if you would like to tag on to what Dr. Smith has said and offer your reactions to this task force.
I don't know how I can really add much more than what Karen just said. I share her enthusiasm in terms of this. You know, this is the most important thing we've ever done in my lifetime here, and it's part of a much bigger movement, you see. And we have a chance to accelerate some things that are long overdue in our profession, and that'll have tremendous carryover. It's just, to me, exciting. I mean, and the commitment that many people have to do this is different. This is different than what has happened before, and it's a broader base, and we intend to make it happen. And I will absolutely do my level best to lean into it and take us places that, you know, together take us places that we've never been, because it's time.
That's great. Dr. Artina Dawkins, I'm interested in your reaction to what Dr. Smith and Dr. Brown have just said about our initiatives, and that I wonder if that might be something that you would be interested in including in your work over at Wake Forest.
Absolutely. It does sound exciting, you know, following up on what Dr. Smith said and with Dr. Brown, you know, it is, I believe it's about time for a lot of things. I like the fact that it's, that reconciliation is included in that, because that's necessary, because there have been consequences of racism in healthcare that have happened. So it's definitely important to recognize that and to close the gap between what has happened, including an apology and other things that will need to occur for reconciliation. And one of my colleagues sent a very interesting article, which I think might be helpful to you, Dr. Smith. It's called, it was published in CNN Health, and it says Black newborns more likely to die when looked after by white doctors. Because what we have to think about in healthcare is the reason why we are in healthcare is for patient care. And if there is something that doesn't contribute to that, then that should come to our attention. And so I just want to read a little excerpt from this article. And it starts out by saying Black newborn babies in the US are more likely to survive childbirth if they are cared for by Black doctors, but 3 times more likely than white babies to die when looked after by white doctors. It goes on to say the mortality rate of Black newborns in hospital shrunk by between 39 and 58% when Black doctors took charge of their birth. And this study it was done by George Mason University, and it was based on 1.8 million births. And in contrast to the gap that was closed when Black doctors took charge of the birth for Black babies. In contrast, white babies were unaffected by doctors and race. So this is just one example of how important this conversation is, and how important it is to reconcile and to just make a note of these different manifestations of racism and the horrible outcomes, and really seek to make a change in that. So yeah, I definitely see collaboration and synergy between this group and and the work that I do.
Well, Artina, thank you for bringing that article to our attention, and I hope you'll share it with the group so we can get it out via our communication channels. Roxanne, I do want to come to you as the policy director at FirstHealth and get your reactions to Dr. Smith and Dr. Brown, and now Artina Dawkins' talking about the Race and Reconciliation Task Force.
I think that is an amazing effort, and I commend the Medical Society for taking the first action, probably first in the nation, to do something about historical nature. And, you know, I hope that maybe the Hospital Association follows along and aligns in some means or manner that they can also sign on to an apology or in recognition of past policies and how racism has impacted care for our people of color.
Super, super. One of the things that I wanted us to talk about today was how our various entities, whether it's New Hanover Regional Medical Center or Dr. Smith's practice or Dr. Dawkins and doing what she does over at Wake Forest or in FirstHealth, and their initiatives in trying to move this thing ahead. We've just talked about the Race and Reconciliation Task Force. Dr. Brown, I want to come back to you. This is actually a question that I had teed up on July 10th, and we never got to it because there was big news down in your neighborhood about the sale of New Hanover Regional to Novant, your partnerships with UNC School of Medicine and UNC Healthcare. And I'm wondering, in all of that, and then there's this community fund, I think, that they're setting up down there. But there's a lot there that seems that we should know about, that you guys are going to start these initiatives on that'll be relevant to what we're talking about today. Could you take a minute and hit some of those highlights for us?
Sure, I'll be happy to. And I want to actually back up because it ties so well to what we were just talking about. I read that same article that we were just talking about this morning, and it really it resonated with me about the magnitude of our task. And so what we started doing would have been in 2017, as we, as an organization at New Hanover, our health system, not just hospital, but the entire health system, really made a commitment to drive health equity by making the physician community look like the community at large. And so we set goals in 2017 around recruitment to have ultimately to create an inclusive medical staff based on, you know, race in particular is a problem in our area, but so is gender amongst physicians, and so is sexual orientation and gender identity. And so we committed to these principles in 2017 and geared our entire physician recruitment along those lines. So in 2017, 5% of the new physicians that we recruited to the community met these criteria. And then in 2018, 20% met it. And then in 2019, 33% met those criteria. And right now on our active recruitment list, it's back to about 17.5% of the candidates that we're considering for positions meet those criteria. And so what we tried to do was put a very laser focused intentionality around making sure that we created our workforce in the image of those we serve. And it's beginning to work. We still have a good ways to go to get our total balance where it needs to be, but you can already see through the influence that has come into the provider community how the philosophies are being enhanced, and we're just better. I don't know any other way to say it, that by having those different mindsets, that thought diversity that we always talk about, but also diversity in those very visible ways, it's changed us. It's changed us already, and it's going to change us for the better even more. And we're really excited about the potential partnership with Novant and UNC. You know, we don't know for sure that that's going to come to fruition. We'll get a much better idea on October 5th, because our setup is governed not by the terms of the deal, but by the politicians. You know, 5 county commissioners determine the fate of our health system. So we're hopeful, though. Everything looks positive, and we're excited because we know that Novant has done some wonderful things in terms of creating inclusive leadership throughout their organization and doing some wonderful things in the community around health equity, many of which are similar to what we've pursued, but on a grander scale. So we're extremely excited about the opportunities that brings. And, you know, it's still kind of in the keep your fingers crossed stage for us right now. And quite frankly, if it doesn't come to pass, many of the things that we're doing really don't change anyway in terms of this, I would say, relentless pursuit of health equity in our community. You know, it just means we'll have to do it differently, because along with the deal with Novant and UNC, what would come into our community is dedicated funding in a profoundly different way. I mean, it brings real money to many different entities. It gives us $50 million right off the top toward mental health and substance abuse issues. It gives us $50 million into our NHRMC Foundation, where much of our focus is around equity efforts. It gives us $200 million to help our employees, which we can target and have, generally speaking, plans that really help solidify the economics of our employees with the lowest paid employees proportionately getting, you know, a bigger lift. It gives us also $1.2 billion in a foundation that is going to would be governed by its own board, 6 members appointed by the new hospital board and 5 members appointed by the county. And this money has to be dedicated in only specific areas that are pertinent to the strategic plan of the county. So you're looking at things like, you know, health equity is one of the areas that actually is dedicated within that plan, as is community development, community safety, and education. So it really will provide us, when you put that on scale for our community, it's about $50 million a year, and the county budget is about $350. But this $50 million a year is really in perpetuity the way the foundation is being set up. And so it is potential for a true metamorphosis. And of course, there's a lot that goes with that. You got to get the right people on that board and making the right decisions. And, you know, quite frankly, we know that our community has been one of the worst in that regard. If you look at history, right? I mean, you can make a case for Wilmington, North Carolina as the epicenter of the white supremacy movement in the country. You know, so we got a lot of ground to make up. A lot of that we have made up, and there's a huge emphasis around it. I'm very excited about what's happening in our local government. Some of that's due to our influence, and some of it is just due to having enough people with higher minds to make it happen. But there's a lot of good going on. We're real excited about it. And if all this comes to pass, I think you'll see great things out of Wilmington.
Thank you for that update. That's very exciting that you've already, you know, made your recruitment goals tick up in 2 years, both double digits. And it sounds like October 5th has the opportunity to really gaslight what you're already doing. So that's really exciting. Roxanne and Becky, I want to come to you and give you guys a chance to, you know, fill us in on some of this exciting stuff that maybe FirstHealth is up to. And maybe we start at the hospital level with Becky, since you are the CEO of a hospital down there, and you can tell us a little bit about what you're doing and what you're planning to do in terms of some of these initiatives with your hospital and then FirstHealth.
For FirstHealth as a system, we are a small rural system. And that gives us an opportunity as a system to start to look at policies, procedures, systems to assure appropriate diversity and inclusion at the system level with physician recruitment, executive recruitment, promotion of team members within. I want to speak a little bit more to what's happening at FirstHealth Montgomery Memorial Hospital, where we are more at a micro level of starting the local conversation with representatives of our diverse communities. We were given the gift of representatives of various Black residential communities where they have for probably centuries at this point resided, worshiped, studied, supported, shopped locally, and are very established communities, representatives of those communities who've been working with us to help us create inroads in improving health disparities, were willing to come and have a conversation with us about what the experience is like for Black and Brown people as they interface with our health care community, with our hospital, with our medical staff in their clinics, with other services in our small medical community. They were willing to have the conversation, let us know what they were experiencing, and then to accept an apology and an invitation to help us make it better. This group of community members have now agreed to be part of an advisory group who will work with us on our policies, our procedures. They will look at our quality data. All of us collect quality data, whether it's our patient satisfaction or our ER throughput times. They shared examples with us where they were able to share the experience. It might have been their personal experience or other community members' experiences where the impression they had, the feeling they had was that they waited longer in our emergency department because they were Black. We haven't looked at our throughput times and sliced it in terms of race or ethnicity or gender. We didn't know if we had the ability to. So you go back to your systems and you start to look at that, and we will now be taking that data back to this group so we can talk about it. If we are giving people the impression that that they are treated differently, how do we communicate differently? How do we retrain our teams so that they can communicate that they are caring? That is what our community is asking for, is to experience that they're being cared for. Giving this community and these representatives the access to bring that information, to make sure each of them has my phone number. I handed out my cards with my personal cell on it so that they know their voice, their experience is critical to us. So they will be engaging with us as we work with a national group, Common Health Action, to begin some thorough assessment, not just here, but across our system. Look at training, look at our strategies, our policies. How do we do some things to catch up with our neighbors in Wilmington? Looking at our leadership development and overall implementation. So more of a micro and perhaps a little behind, but happy to start this journey with great energy and great support with a local conversation.
Well, that sounds like you guys are really engaging in it, and I do want to get Roxanne's perspective again, maybe from a higher up system perspective, given that I think it's 11 counties. Is that right, Roxanne, that you guys have a footprint in? I know it's multiple counties. So while they're rural, you still have the ability to influence a larger swath of real estate down there in your area. So Roxanne?
Right, and I want to thank Becky for really being open to hearing the community voice. They had initially shared some stories through our connective group that we meet in our community groups, and how this kind of came about was through a community-centered approach Blue Cross Blue Shield grant that we were working on in Montgomery County, and that included some education on equity, diversity, and inclusion from Common Health Action. That's kind of how we got connected with Common Health Action. And I've been through equity, diversity, and inclusion trainings that I've walked out and been like, okay. This training by far really made you lean in as an individual and lean into the words of privilege and lean into the words of racism and lean into the words of all the isms and the history and why and what is our part and how do we be part of the solution? How are we part of the solution? So it's kind of how that started at the Montgomery level, but I do want to say that although Becky is saying we're at the very beginning stages at Montgomery Memorial Hospital, and we are, there's also a commitment due to a conversation that Becky had with our leadership and our relatively new CEO to actually take this concept, learn our lessons in a smaller environment, and scale this system-wide, again, to catch up with our Wilmington neighbors, to ensure that we have an inclusive organization. And through some readings that I've been doing recently, you know, I'm challenging myself, like, healthcare has usually been cultural competency. And what is that? Like a 30-minute training, and we walk away and we all say, okay, we're culturally competent. What comes first, cultural competency or inclusion? I think in my readings, I just read that an inclusive organization has reached cultural competence. I don't know if I agree. I don't know if it's the other way around, but I look forward to this journey and learning lessons and scaling it across the region and also learning from our neighbors. And clearly, Dr. Smith is also in our region. So making sure we work inclusively with all of our partners to make sure this is across the board internally and also how we interact in the community. Right.
Well, you know, as part of the medical society, we had some training from the Racial Equity Institute, can't get it out, a couple of months ago, and Dr. Smith and Dr. Brown were with us for 2 days, and it was like the training that you mentioned, Roxanne, was so informative, so powerful, and it's clear that we all have so much work to do now together, so it's nice to hear that everybody's in the same boat. Artina, I do want to come to you and give you an opportunity to jump in on this conversation about some initiatives that you guys may be involved in over in your neck of the woods.
Okay, yes, thank you, Franklin. Like Becky, I kind of want to piggyback on her format. I wanted to start at the macro level because I am positioned within a department as a program manager. So right. That makes my position for leadership unique, but still impactful. So again, starting at the micro level, as co-director of diversity and inclusion and the first African-American member of our interview committee for residency, I and the team were able to facilitate our most diverse intern class ever. Because I believe that really to make a substantive change, and that's for any topic, racism or otherwise, it requires buy-in from all levels. And interns are they are our future doctors. I mean, there are, I don't remember the number, I just looked on the ACGME's data resource book, but there are thousands of graduates who graduate every year. And so starting at the level of residency and fellowship is a great opportunity to really make a change and move the needle on positions of racism and combating racism. And so we were extremely proud of that. With this being our diverse group, we had one African-American male and one African-American female, our first, since the program was started in 1969. And also through the Kennedy Hopkins Scholars Mentor Program, it's an interdepartmental program. And so we are able to even close the gap of professional and personal support for residents and fellows and bring in content that focuses on that audience. And one of the tenets of our program is community engagement. And I heard that different ones mentioned the importance of community engagement involving the community. And I think that's a good as far as helping to rebuild relationships that have been really negatively impacted based on the history of discrimination in healthcare. And moving up further, the Office of Inclusion and Diversity has initiated a lot of diversity efforts. And myself, with Kennedy Hopkins and other colleagues collaborate or have collaborated to start the affinity groups. The Office of Inclusion and Diversity started the group, and it's for marginalized groups so far. And those include African American affinity group, a Jewish affinity group, an Indigenous Peoples affinity group. There's one for Veterans Administration. And so each of these groups are able to gather and do efforts based on common interests. And I think these groups, have started about a year ago, and it has become very, very powerful. And actually, we are starting to plan our first leadership conference based on the coming together of folks of color, which is super powerful, and just a great opportunity to really bring content to that demographic. And so, it's like they're subtle changes, but they're meaningful, and they're building on each other. And so, and moving even further up, the Maya Angelou Center for Health Equity, the director is Dr. Goldie Bird. I'm an affiliate faculty with that office, and one of her main research efforts is in Alzheimer's research, which negatively impacts the African American community. And so there are collaborative efforts there. And she has been tasked with a race and equity task force that's going to survey different aspects of the medical center to see where real change can come. And so I think although it is a macro level going up, there's a lot of opportunity in it. And if we really want to make a change and really get the full impact of these initiatives, it's important, again, to get buy-in at all levels and include all levels in on this conversation. Thank you.
Yes, ma'am. I totally agree. We need as many people to get on board with this thing. Dr. Smith, I do want to include you, even though you're at the practice level. Clearly, you're at the North Carolina Medical Society board level and a lot of other things that you're involved in, but you're also the Chief Medical Officer for Aledade in the state of North Carolina. So I didn't know if there were any initiatives within Aledade or in your practice setting that you might like to share with us.
Absolutely. And let me say, I want to start with a little bit of a story. And then I'm going to kind of bring it out. So yesterday I had the opportunity of being the patient, and I visited the physician, and I had a particular problem, one that could be the result of domestic violence. I'm a physician, and I was asked, have you had any injuries? And I said, no, I haven't. Are you sure you haven't had any injuries that you didn't know about? Like, no. I haven't. And so as I was watching the typing on the electronic health records, it was put down occult injury ? And I was like, and so I began to wonder, did I just get discriminated against? Was this racist, or is it the And I had to wonder because my spouse was with me, and then it made me think, well, are they thinking that I had domestic violence and my husband hit me? I don't know. But it really said to me, it's so subtle. And so what I'm getting to is that individual accountability. It doesn't matter how large of an institution we are. If we are a provider of care, we are a physician of care, we have to have understanding of what is our own implicit bias and what are we adding into a history that wasn't there because of our own bias. So it doesn't matter the size of the institution, it's that physician-patient relationship that we start with, that core unit. We also have, moving up a little bit in our office, what is the accountability? Each one of us are responsible for the interaction that we have with the patient and how we make them feel and what we have projected on to that encounter. And that doesn't matter whether it's a little tiny office such as myself or whether it's a very large institution. What is our accountability? And what about the people who we hire in our office settings, in the institution settings? And I appreciate the idea of hiring people that look like the people who are being cared for, who are being catered for in that setting. And so as part of Alidate, and I'm actually a local medical director, I won't take the honor of the CMO away from my colleague because she has a lot to do. And so, but as a local medical director, there are 4 of us in the state, and we are able to provide insight from each of our different regions. And we do that, whether it's down east or whether it's in the southern part of the state or the northern part of the state. And we're able to come to the table and discuss what are those issues that are affecting people who we are caring for, causing lower than desired health outcome. And as an ACO, as a shared savings plan, we need to make sure that we are providing efficient and cost effective care. So as part of Alidate, we are looking at the diversity in terms of the physicians and the providers. How can we increase the number of those physicians participating in the ACO? We are also looking at how do we engage with our patients, because the study that we heard this morning was very interesting, that I just heard another study where African-American patients, despite correcting many factors, still continue to have higher LDL rates. And then if they have higher LDL rates, then that means those individuals are going to be at higher risk for heart attack and stroke. Well, that's going to impact the cost of the ACO in terms of hospitalization and so forth. And so what can we do to minimize that impact? We also spoke about how can we coordinate with NC Care 360 in terms of addressing SODH in our communities. And so there's quite a bit that an individual physician such as myself can do as an independent, as part of an ACO, and being a patient. So I will give that system some feedback, and I might send them an article or two, but getting that side of it from the patient side does make a difference. We can affect change in so many arenas.
Thank you, Karen. And I want to bring something up to everybody that you had sent around to us, Dr. Smith, this morning, Strategies to Becoming a Multicultural Anti-Racist Institution, which I think is an outstanding document. And I wish we'd had time to get into it more, but I do want to bring it up because I think it's relevant to the last question, and it gives you guidelines for moving across a continuum. And I didn't know if anybody on the panel who I'd sent this to wanted to comment on it, but I just wanted to bring that out, and we're going to be sharing that with folks through our channels. So Dr. Smith, did you have anything else you wanted to say about this?
Yes, now this document, and I must admit, I am a true academician. The sources for the document are certainly listed. The original is not my work, and so it is borrowed, but it was so good. I felt like we needed to share it, but certainly recognize the sources and reach out to those entities, acknowledging where it came from. But it is a nice strategy to get started. It really does hit on several points. And for those of us who are in organizations that desire to make a change, it is a start. But I must say, it is so important to understand the historical perspective of where we came from and how did we get to this point in time. And the entities in our state, such as the Race Equity Institute, and there's several, to search out because they really have a lot of knowledge. I know Sandy Darrity's group over at Duke. There's a lot of folks who have been doing this for so many years. Now is the time to seek them out so that we don't run into this trial and error as we change our institutions. But let's use some really good educational sources and folks who have been doing it for a long time.
Yeah, I totally agree. And the events in our country that have gotten us to this point, we really need to take advantage of this time to move some of these initiatives through. I want to come back to Dr. Brown and then to some of the other folks and talk a little bit more at a granular level about COVID-19 and lessons learned. You know, we started, I guess, in North Carolina in earnest in maybe March or April when things really started to take hold in our state. I feel like we've learned a lot maybe about treating COVID, and maybe we've learned some things that we don't want to do, right? But I'd like to start with Dr. Brown, and maybe you can discuss what New Hanover Regional has learned about treating COVID and some of the things that you are doing, not just at the hospital level, but maybe in some of your community-based clinics.
Absolutely. Well, it has been a fast learning curve. And right now we're at the stage where clearly for the sickest hospitalized patients, we're better at treating it, you know, and some of that's because we know remdesivir has a good effect. We know some of the steroid protocols seem to work. And so those things are all helping the way we manage patients prior to and during the mechanical ventilation and all those kind of things, you know, we've gotten better at the end stage. But the truth of the matter is in COVID-19, what works are real simple interventions, you know, and it's very interesting. The things that work are simple, but they're hard to do. You know, because it's hand washing, it's physical spacing with people, it's not gathering. All of those things fight human nature, and then of course the masking, which is unfortunately was tremendous, still is tremendously controversial. The biggest lesson we learned though was something that we thought we'd already learned, but we relearned it, is that it is so easy to miss populations in communication about what to do at a pragmatic level. So very early in the experience, we got out and communicated well across sectors of the community, and we did this very intentionally, and we used connections that we have, whether those were faith-based connections, whether it was along the lines of different ethnicities and races that we were connected with through various organizations like NAACP or the Latino Alliance at the university, and just used our employee resource groups to help really create those connections through media, through mass media, you know. And then we were doing great, you know, like a lot of the state was. And really before the phase 2 process that escalated things across the state, we had our first miss, and it was in the Latinx community, because what happened was we didn't take into account seasonal variation in that population. And so we had a big influx of residents to North Carolina based on the agricultural processes in our surrounding region. And none of them got the message for several weeks until we realized that they're doing certain behavioral practices in those communities that clearly indicated they hadn't gotten the message. So we retooled back out and got that message out, you know, and then again, so then we started seeing that important behavior change at a high level again. But it just, sometimes these things are the simple pragmatic things are the easiest to overlook. And that's what we've seen. You know, our practice environment was enhanced greatly because we went from doing about, I mean, less than 100, I'd say less than 100 video visits a year to 10,000 in a month and up, you know, like, and it's really interesting. So what we found out there, again, was a very pragmatic thing. From a technology standpoint, we could have been doing that for years. It was a behavior standpoint, mostly from our physicians that really resisted it. But a lot of them have now figured out how to make the best out of both worlds. And so that's been really fabulous to see. In fact, I had the president of our medical group, who's a general internist, has now figured out how to hit 75% of his productivity level in half a day while on vacation using video visits. And it's like, yeah, it's amazing that just by people using the COVID opportunity to say, hey, I need to maybe think differently. We've found these opportunities. And I think that actually is building a skill set that if we continue to think differently, it can help us in some of these other areas too.
For sure. Becky and Roxanne, I do want to come back to you, starting with Becky at the hospital level down in Montgomery, and then Roxanne, and talk about maybe the other counties that you guys are involved in, because Dr. Brown mentioned something about missing communication for groups that were needy. You're in a very rural environment, also Dr. Smith down there. And I'm imagining that from migrant farm workers to, you know, your Latinx and certainly your African-American communities down there that are at higher risk. Can you talk a little bit about lessons learned over that time, both clinically treating these folks and also some of the messaging to get them the help? So, Becky, let's start with you.
Sure. Well, in terms of treatment protocols, you know, early on made decisions about where's the appropriate place to treat people who are in acute illness and need to be cared for. We made those decisions early on. That strategy has worked so that we can make remdesivir. We're not going to handle it in a critical access hospital in a small community, but with our referral center certainly are. Establishing drive-up testing for our clinics, looking at what can we do to be as accessible as possible. We were able to deploy remote visits, telecommunication visits that very quickly and in large percentages, and certainly agree that those will continue. My bigger concern, Montgomery County is the second highest per capita rate of COVID infections in the state. Over 30% of those infections are among our Latinx Hispanic community. The assumption is, why didn't somebody teach those people what to do? And the issue here was not that they didn't know, they do know, but because of social determinants, including poverty, that makes it, you know, without affordable housing, we've got multiple households, multiple generations living in one dwelling, making it nearly impossible to isolate. They certainly are struggling with transportation, often one household, one vehicle. So going someplace for a visit is difficult. the access for telemedicine is limited. We do not have high-speed fiber here, and access to technology is expensive. So certainly in our Latin community, we've got social determinants of health that, you know, in terms of housing, poverty, all of the access issues that make it far more risky in that community, far more likely that they're going to experience this illness. Not seeing that in our African American communities, you will not see a more compliant group of individuals than our African American neighbors around masking, distancing, those kinds of things. They are, you know, it's not about knowing, it's about ability to do.
Super. Roxanne, do you want to add on to Becky's comments from a policy director, from a more macro level for the system?
I mean, I think it's more of from a community lens rather than maybe a macro lens, is that there were a lot of confusing messages, a lot of miscommunication, a lot of conspiracy theory on social media. And I think it just boils down to the public does not know who to trust. They do not know who to believe. They do not know what is truth. They do not know what is fake news. They do not know what is real news. And they, you know, these populations may not be grounded in science and medicine and academia. So they're going to turn to whatever their belief is in social media, whatever their network is, whatever shows up in their robot programming. And I think that is something that we, the medical community, really struggle with, and we kind of missed at a higher level. You want to talk policy at the higher level, that got missed. And, you know, the CDC, to the presidential office, to our government, to our governors, to our policymakers, did not have a willingness at the beginning to collaborate and talk across lines and seek expert opinions. And I think that trickled down and really has created this sense of mistrust, misinformation, and miscommunication in our communities that is contributing to our communities of color being confused. And I will, from personal experience, I went into Food Lion, and there it is, you know, a sign in English, you know, don't come in the store without your face mask, face masks required, no picture. And I walk in, and there is a Latin gentleman with no face mask, and his friend with him. And, you know, I'm like, well, no wonder. Like, if they don't speak English and we put up all English signs, then it's down to the micro level. So things went wrong from up top all the way down that created confusion for the most important people to get the messages. And so just America kind of missed the boat on the whole communication effort with COVID-19. And as healthcare leaders, I think it's up to us to kind of step up, take the lead, work in our communities, and try to help now do some recovery work and reinforce what those 3 W's are and those easy, not so easy solutions to the spread of COVID and continue. Another thing that FirstHealth has done is put some efforts out to test for antibody tests. We're having community antibody testing, and our testing in Montgomery, our corporate communications office put out a flyer. Well, my people in the community immediately came to me and were like, Roxanne, nobody understands. They think that they're going to get the swab up the nose, the COVID test. They don't know the difference between an antibody test and a COVID test. And this was real-time feedback. And so I called our corporate communications firm and was like, guys, you might want to put these flyers through us and get some feedback, community-informed feedback on what people understand. And I'm like, no, because the flyer said blood test included. So they thought that meant they're getting the swab and a blood test. Nobody wanted the swab. They didn't want any part of the swab. So they've heard about the swab. So they're like, we're not doing it. And I'm like, no. And, so I feel like we act so closely or so quickly in my networks to get the real word out, And so we learned our lessons kind of in that first one, and they did correct language and put a lens of a community member on it. But it just goes to show, I think, at a system level, at a policy level, that communication is essential and important. And we have a lot of lessons, and I look forward to some journal articles on how communication impacted the COVID response.
Yeah, that's great. Dr. Smith, I want to come back to you, and we're approaching the top of the hour. Schools have reopened. Some of them largely online. Some of them are kind of a hybrid model. Some are trying to, in other states, to put everybody back in a seat. It's highly politicized, as you know. But I'm wondering about you and your practice in Raeford, North Carolina. Have started to see any of the effects of this jumbled up policy about getting kids back to school? And have you started to see that disproportionately affect your patient population?
Absolutely. Let me, getting the kids back to school is another area similar to people needing to go to work. And so I want to kind of address a little bit in terms of those individuals who had to go to work, and they were working in meat processing plants. And we know one of our plants had 795 plus people test positive, yet these individuals had to go to work in order to earn a living. And even if they made the decision, I'm just not going to go in, they were terminated. And so the individual finds themselves in a no-win situation. I go to work, I get the virus, I die, but I might earn some living money before I die, or I get terminated, and where else am I going to find another job and make that decision to stay at home? And so it gets beyond that of not following the 3 W's, wear the mask, wait 6 feet back, and wash your hands. We're in a whole different level of discussion. And it's beyond that of those individuals not understanding. And so then we also look at, here we have our children. I place my child on the bus. I send my child to the classroom, and then the child perhaps will become positive. But if I don't send my child to school, then I'm going to be notified as being out of compliance for compulsory education. It's very similar. And it's just, is this right? And for those parents who have the ability to pull their child out and to enroll their child in a private setting and to have their education online, not exposing the child nor the family, that's where we see differences in terms of the socioeconomic factors. We really have to get back, and I want to mention another source, and I'll put it in, is Moyes Jawa, J-I-W-A, The Art of Doctoring. How do we get back to connecting with our patients and understanding how circumstances and situations change, but do we understand the impact that it's having on the decisions that are occurring in that individual and in their home? And so the school situation is one, yes, is fraught with miscommunication, but we also recognize, the impact of families having to make a decision, and their decision could be right or wrong, similar to those employees who had to make a decision to go to work. Is it right or wrong? And what's going to happen to their life based on the decision that they had to make? So the school issue is literally landing us in the same arena. And if we could get a consensus across the state to test every child before they go into the school, and make sure that our communication is consistent in terms of protecting those children once they have tested negative, that might be a good start. But we have not received a consensus on returning kids to school, either definitely from the national level, and we have a lot of fear from the hybrid or forced models that are being told to these parents.
Well, that's a great answer, and you've given me a lot of information and hopefully some other folks, because as a parent of 2 teenage boys at the college level and the high school level, I've heard a lot of this stuff going around. We're at 2 o'clock, which is our hour. I want to thank all of our guests today for a wonderful conversation, and you guys are all doing great work to alleviate some of the pain from what we're talking about. We got to keep this going, guys. So at some point we will re-engage. But I want to thank you. Tina, back to you.
Thank you so much, Franklin, and thank you so much to all of our guests today. It's been, as always, a very inspiring conversation. And I just want to add one comment, and I think one individual accountability that we all have is also to ask what we don't know that we don't know, and question the norm that we are navigating in, and make sure that we don't, we didn't touch upon that today, but that's another topic for the next time, but make sure that we don't take for granted that the norm that we are navigating in is the right one, that is the inclusive norm, if that makes sense. So with that little comment, thank you so much again. We will come back later in September to continue with this conversation. Hopefully we will see the same guests again to continue. We like consistency, and we thank you so much for taking the time to be part of this. Thank you to all of those who called in and joined us in the audience. And just to remind you about our next power session, power hour is going to be around alcoholism. We're going to come back, we're going to take a short break and come back on September 11th, and then we're going to come back probably 2 weeks later and again discuss racism. With that, I hope you all are doing well. I hope you're all staying safe. We thank you for all that you do, and we thank you for allowing us to be part of your journey and for being partners in helping to amend this in society. Thank you so much, and take care.